right. Good morning, good afternoon, everyone who has managed to join us in today's webinar. Today's webinar is the second in the IANPHI Africa Webinar series in 2023, where we want to discuss innovative approaches to public health emergency response and policy decisions. We want to see how we can do things a little bit differently, not as usual. And we have innovative approaches that are going to be presented to us today. And today, we have speakers from the CDC Foundation, the National Institute for Communicable Diseases in South Africa, and Resolve to Save Lives. That will discuss the current status of data to policy in Africa, current successes and challenges of the data to policy program, and the 717 target for outbreak detection and control. And to do that, we have our panelists, Ancharski from the CDC Foundation, Ruvimbo Chingonzoh from the National Institute for Communicable Diseases in South Africa, and Mohammed Lamorde from 717 Alliance Resolve to Save Lives. And today I'm your moderator, Ario, who is the director of the Uganda National Institute of Public Health, but I'm also the chair of the directors of public health in Africa. In other words, I chair the IANPHI Africa network. And my deputy is Hav Hien, who is a director from Burkina Faso National Public Health Institute. I hope he has managed to join us as well. Now, in this webinar today, we're expecting, of course, directors from National Public Health Institutes in Africa and also around the world and from other regional networks. And then we expect, of course, technical staff from National Public Health Institutes in Africa and also around the world, and Ministry of Health staff who had expressed interest to listen to some of these innovative approaches. And of course, we also do have representatives from IANPHI partner organizations. So just a few housekeeping information. I want to let you know that you're free to use the chat to share comments and ideas related to the discussion, and also to ask questions at the right time. But as the presenters are presenting, you can use the Q&A box. You can post your questions and whatever. And for those who manage to send their questions early, it will be posted on the chat, and then our panelists will be able to respond to some of those questions. Please also be reminded that the webinar is being recorded, and the recording and speaker slides will be made available to you after the webinar. So I don't know whether, Charlotte, you could share the agenda, our agenda for today. But in the meantime, as you're sharing the agenda, our agenda, of course, is welcoming participants, which I've done, and then introducing the session, which I've done. And now we shall go to the presentations. And our presentations will start with Andrew Ancharski, and then Ruvimbo Chingonzoh will give us some bit of experience of how they implemented data to policy in South Africa. And then we shall wind up with Mohammed Lamorde from Resolve to Save Lives. So to start our discussion, I want to introduce our first speaker, who is Andrew Ancharski. So Andrew is actually a epidemiology and health policy trainer with the CDC Foundation. Andrew, can you kickstart the presentation, please? You're welcome.
Thank you very much for that. So yeah, I'm going to give a kind of overview of the data to policy program. which is funded by Bloomberg Philanthropies underneath the Data for Health initiative. So kind of an outline of this talk. It'll be a kind of background, like I said, on data to policy, and then the structure of the program, and then numbers of and statistics on the data to policy training program, and then finally specific examples from the countries that we work in Africa for data to policy. So the Data for Health initiative.
A Data for Health Initiative, dados para a iniciativa de saúde, tem ajudado vários países a coletar melhores
recursos a alcanzar su meta de salud. Tenemos el CRBS, que es las estadísticas de cáncer o estadísticas vitales de cáncer, que van a estar recopilando información de mortalidad.
Y
aider les pays à revenus faibles et intermédiaires à collecter et à utiliser de meilleures données de santé publique en renforçant les systèmes de collecte de données sur les naissances et les décès, CRVS. Donc, le programme de l'impact des données comprend deux programmes. Donc,
en este momento, el CDC tiene diferentes países activos: Bangladesh, Ruanda, el sur de África, Tanzania, Tailandia, y tenemos también Uganda y Zambia.
Nós oferecemos assistência técnica do uso de dados para informar normas e criar programas de ação.
Trabajamos con estos países y entrenando a los participantes también, y esperamos que los institutos de salud pública guíen la dirección en la que estamos avanzando, así que sea un programa colaborador o una experiencia colaboradora. Y conforme también a los temas de política, estamos trabajando con el Boletín de Salud Pública. Y estamos teniendo la ayuda de poner estos boletines en los diferentes países con los que trabajamos, y comunicaciones científicas con las que damos talleres para trabajar con estas comunicaciones de muchas formas y maneras. El programa de datos para las diferentes políticas fue desarrollado con lo que son las estrategias vitales del Centro de Control y Prevención de Enfermedades del CDC y lo que es la fundación del CDC. Y esto es para sellar o cerrar la brecha entre lo que son las personas que hacen estas políticas y la salud pública. Y esto es un entrenamiento intensivo o un programa intensivo de entrenamiento, perdón, en el que nosotros estamos trabajando con las personas para que entrenen a otras personas también y poder hacer un programa sostenible.
So this program really helps to develop analytical skills using epidata, doing root cause analysis, health impact assessments, and economic evaluation. That economic evaluation is an aspect that often is the most difficult to teach. It's the newest kind of topic for public health institutes that we work in. There's not a lot of background in this economic evaluation, so it tends to be a more intense section of our training. So the goal is that these D2P participants will develop data-driven policy briefs and recommendations. They are really, as I said before, in collaboration and around current priorities of the Ministry of Health. So we're constantly talking back and forth saying, what are you guys prioritizing? What do you need? What are the topics? What are the health concerns within the country? This is currently trying to be done more and more with that CRVS arm. So using data around mortality surveillance, birth and death records, and trying to really help policies in that aspect. So not only are we trying to strengthen skills of participants, but also creating actionable policy proposals. So the training program, I kind of talked about the goals and the content is, really a structured course. Some people have said it's, almost to the length of like a year master's course, but it's really condensed. I think a lot of these skills are enhanced during the course. So it's an aid to help these mid-level, high-level public health professionals. And then it's done over 3 to 4 months with a variety of structures that we will go over here shortly. So to run the D2P program, we really start with stakeholder engagement. We're asking, who, what, why, what do these NPHIs really want to have done? Who are going to be the people that have the decision capabilities to change these things, and then what's the data behind that? So those questions really need to be asked before we start the D2P program, and then within the D2P program we start the policy brief, writing, analyses, everything, and compile that and present that information in a policy forum to those stakeholders. Once that's done, we usually take those participants of the D2P program, train them as mentors, and hopefully have those mentors then be able to complete that program again with a new group of participants. So once that's all done, we kind of try to promote these policy briefs through the country, through continued advocacy, publications, journals, opinion pieces, and that public health bulletin that we talked about as part of the data impact program. So the data policy training timeline, so that development of the policy, we have a first session, training session 1, which really goes into the economic and epidemiology analysis. So here we're looking for numbers, we're looking for kind of a policy option, so an intervention really that can hold weight and be economically feasible and improve some sort of health outcome. Then we take 8 to 10 weeks, sometimes longer, depending on how difficult it is to get the numbers, and help those participants go through and really stamp out their model. So this is done often with a decision tree using cost and prevalence data for their specific topic. And then we give another training session on how to compose and write the brief. And then finally, we get to an implementation phase, which is part of the policy brief. And then, but that policy brief in the policy forum is one route, as I discussed before, to present that information that these people developed. So hopefully people within this program gain skills, produce a policy brief, present that policy brief, and make change. So what have we done so far? Data to policy in one form or another has impacted 20 countries with over 36 trainings and 11 train the trainers. Actually, as of 2023, this number has gone up, but on the right, you can see the countries that we've had trainings in so far. So not only is this in Africa, but it's in other regions of the world, with the goal to really take data and use it to inform policy. These are the participants, a breakdown by year and sex. So we've had 614 people take part in the training, with 93 mentors trained. that number of mentors is going up significantly as we put a focus recently on training the trainers. So we are going to have a much larger cohort of local instructors throughout Africa and throughout our program areas. And that number for 2023 will continue to rise. So policies created and passed by country. So we've had 167 policies created in our now 9 years or 8 years, with 66 of those impacting policy. If you notice in 2023, a lot of the policies that were created have yet to have an impact, but as we were discussing before in the timeline, there's a lot of lag time. It takes a while to get these policies passed. So now I'm going to discuss what we've done so far in Africa. So CDC Foundation has 5 countries in Africa currently, and then there's another 4 countries that have had a data to policy program run so far. And in addition, I think, so Ethiopia is also a country, but has yet to have a program run. So the CDCF countries are Rwanda, South Africa, Tanzania, and Uganda. So Rwanda has had 2 trainings with 6 policies produced. Their topics are stroke, antimicrobial resistance, malaria, measles vaccination, hypertension, and cervical cancer. They had a really neat policy on antimicrobial resistance that we're currently working on getting developed. It's part of our program right now, but it looks like they will have a very good outcome of 250 potential deaths averted. And then we will have the next training of trainers in 2024 as our next program. Tanzania has had 2 D2P trainings with 10 policies produced. Some of the notable policy topics, maybe obesity, maternal mortality, neonatal mortality. Those are the non-communicable diseases. And then it had the infectious disease policies on HIV, malaria, and rabies. They had a nice policy on continuous donor-dependent distribution of insecticide-treated nets, with quite a few deaths averted for under 5s at relatively low cost per death averted. Uganda is another CDCF country, and they've produced 5 policies so far. And we recently did a training of trainers, and we've been able to use those trainers in other countries. And now we're going to set up our next D2P cohort in October 2023. And we have those policy topics selected. It looks like we'll have 4 or 5 groups, and using a lot of collaboration with the field epidemiology training program. Zambia has been one of the longest standing partners, and they've had 5 trainings all the way back to 2016, with many policies produced around a variety of topics. They're actually holding their next D2P cohort in October 2023, and it will link, it's focused mainly on using those vital statistics numbers in developing policy. One of the interesting policies that we found from there was on the introduction of youth-friendly clinics to increase adolescent HIV testing. We're always looking to build in equity with these policies, and that's one that could greatly help in many countries. And there's a lot of overlap between functional policies between countries that could work for other countries. Now getting into the non-CDCF countries, I'll briefly go over these. So Cameroon had 1 training, they were with vital strategies, and that training was actually in French, and the next one's expected to be in English. So they had a couple of interesting policy topics as well. Ghana was a former country that produced 1 policy on the training in 2017. on bacterial meningitis outbreaks. Kenya is a recent vital strategies country as well, and they had a D2P training this year with 4 policies produced, and they expect to have both a TOT and a D2P coming up in this phase. And Mozambique had 1 training in 2023 with 2 policies produced with vital strategies, and they hope to continue working on those policies in this next phase and in other trainings. So that's kind of a brief background on some of our countries. I don't know if you noticed, but I did not include any information on South Africa. So Ruvimbo will be talking about data to policy in South Africa. Thank you so much.
Thank you so much, Andrew, for that wonderful presentation. So I think to give the practical perspective what Andrew has presented, our next presenter is going to be Ruvimbo Chingonzoh. Ruvimbo is a field epidemiologist employed by the National Institute for Communicable Diseases in South Africa. She works at a subnational level, providing epidemiological support to the Eastern Cape Provincial Department of Health. She has worked as a veterinarian and is passionate about zoonotic disease control and applying One Health approach. And she enjoys hiking along local hiking trails. Ruvimbo, the floor is yours.
Thank you very much, and good afternoon. Thank you for having me, and thank you to Andrew and Chandra for inviting me to share my reflections as a participant of the D2P program. My presentation will include an overview of the policy briefs that were produced by the first cohort of the D2P program in South Africa, as well as my reflections on the D2P program itself. I'll begin by framing this within the broader policymaking process in South Africa, as is described in the National Policy Development Framework. This is based on the understanding that there are different types of policies, such as regulatory policies and department-specific, or rather sector-specific policies, and also on the understanding that policymaking is conducted at different levels in the country. Policymaking in South Africa follows a process that begins at a political level, where a declaration of programs or policy to improve the lives of the citizens is made. The declaration is informed by a number of aspects, including problems and opportunities that have been raised by the population. And priorities that are declared are processed through the government for implementation. This implementation includes a strategic plan that sets out the actions to be taken and provides as well a framework for the national, provincial, and local government plans. So the detailed action of the strategic plan are then deliberated, and they are announced to the public via national, provincial, and municipal addresses. So this is a broad overview of the process, but narrowing this into policy making, and specifically focusing on the 3 sections that are highlighted. This shows how the government translates public declaration into policies and laws, remembering that there are different types of policies that can be developed at the different levels. Policies developed take into account the provisions of the South African Constitution, National Development Plan, which is abbreviated NDP, and integrated development plans, as well as analysis of the political, social, economic, and other landscapes that include international obligations. The government develops and implements policies, including sector policies, which the respective departments, including the Department of Health, must then strive to execute. Sector policies are derived from the mandate of the respective department or ministry. Between September 2022 and February 2023, the first D2P training workshop was held to capacitate the South African public health professionals to be able to use public health data to inform public health policy. A total of 20 participants were trained, and a total of 6 policy briefs that spanned various topics, including cancer, neglected tropical diseases, and other communicable diseases were developed. In July 2023, 7 D2P participants who had participated in the D2P training then participated in the South African D2P training of the trainers workshop. And this group included NICD epidemiologists and a health economist. Now, looking briefly at the policy briefs that were developed by the first South African D2P cohort. 2 policy briefs were developed that focused on neglected tropical diseases. The first policy brief sought to identify strategies to implement WHO recommended mass drug administration strategy to reduce the prevalence of bilharzia, also known as schistosomiasis in South Africa. Recommendations from this policy brief have been adopted for implementation, with an implementation plan having been circulated to the South African Neglected Tropical Diseases Working Group. The implementation plan will also be tabled at the next National Essential Medicines List Committee meeting, which is a quarterly meeting. The second NTD-related policy brief sought to enhance human rabies control to ensure progress towards eliminating dog-mediated human rabies. This is a policy brief that my team and myself worked on. And the recommended strategy was for the implementation of an integrated animal bite surveillance strategy, animal bite surveillance system, which was coupled with tracking of rabies post-exposure prophylaxis. There have been engagements on the implementation of the recommended policy brief. The third policy brief looked at improving surveillance of rubella and congenital rubella syndrome as a key step towards elimination of rubella. Policy recommendations for this policy brief are being enacted currently. Events at a national level, that is in preparation for rubella vaccine introduction in the expanded program for immunization program, have fast-tracked the implementation of policy brief recommendations. The NCD chairs the surveillance subcommittee of the technical working group that is looking at introduction of the rubella vaccine into the extended program for immunization. And as such, the forum has been used to advance the policy brief forward at a national level. Utilizing a standardized screening tool to optimize HIV testing among children in South Africa is a fourth policy brief that was developed by the South African D2P cohort. And the context analysis established that standardized focused testing of those that are at increased risk is required. The National Department of Health began with a small-scale implementation of the recommended recommendations from the policy brief. And this is now being expanded. So the screening tool is expanded to be used in all South African facilities by the end of 2023. So yes, the recommended policy option is being enacted. The alternative policy option, that is using training to increase the number of children that are tested, is also being implemented, with the national curriculum being in development. From a quotation from a member of the team, of the policy brief team, was, all in all, our advocacy work was well accepted and has been followed through. The cervical cancer policy brief made a call for inclusive vaccination coverage against human papilloma virus, which is HPV. This is the leading cause of cervical cancer incidence and mortality in South Africa. The brief identified interventions to address limitations within the status quo, with the policy brief recommending enhanced facility-based vaccination programs as a cost-effective method to achieve the HPV vaccine coverage goal. The proposed policy options have been deliberated, and the National Department of Health is working to implement the policy brief recommendations. An alternative policy option that was proposed by the policy brief has been implemented, with the HPV vaccine being extended to girls that are attending private institutions or educational institutions. A member of the policy brief team is also sits on the national committee that is developing a strategy to achieve the 90-70-90 cervical cancer elimination strategy. Thus, the participation of the NICD at national forums has been leveraged to advance policy briefs forward. The final policy brief sought to improve vaccine coverage in South Africa to prevent polio outbreaks. The policy brief was developed taking into account interplay between reported wild poliovirus type 1 outbreak that had been reported in Mozambique and Malawi, and the low vaccine coverage that had been reported in some South African districts, coupled also with the patterns of travel and migration within the region. The policy brief recommended that there was a need for the introduction of preemptive supplemental immunization activity campaigns, and it identified the need for further collaboration with the Ministry of Health so as to develop the model that they used further. And this policy brief is being prepared for publication. As a D2P participant, the program has provided me really with an opportunity to directly participate in health policy formulation. As a field epidemiologist, I work at a subnational level, and which is actually the provincial level. And this is commonly or largely where public health policy implementation occurs. The D2P program introduced a tool that I, as a public health professional, can use to influence health policy, and that is to directly influence health policy. A strength of the program is that it is an intensive hands-on learning experience that culminates in a policy presentation at a policy forum. And this is a key milestone, I believe, for policy development and for the policy implementation process. The D2P program also allows for peer-to-peer learning and it provides opportunities to interact with and receive inputs on the policy brief from the mentors, facilitators, and other participants of the training. It also provides an opportunity for one to track and review policy brief development within the cohort. For example, we were working on human rabies control, but we had an opportunity to also track and follow policy brief development across the various public health problems that were being addressed. And it also provides an opportunity to upskill, such as introducing the concept of a policy brief and how to develop it, and introducing economic evaluation methodologies. The D2P program is an intensive program that includes self-learning and a facilitator-led session. The units and modules are well structured, I believe, and they gradually build up to the policy brief. And a key success factor of the D2P program would be the mentorship aspect. And what is also interesting about it is that the program has an accountability or a progress check that is built in, where at the end of the module of a specific module, the teams have an opportunity to present a component of the policy brief that was covered by that specific module. So team members have an opportunity to present at each of these sessions, and this therefore ensures participation across the team. My highlights of the program is firstly being able to escalate human rabies and human rabies deaths as a local public health problem. We were able to conduct a focused problem analysis. We evaluated and proposed policy options to address the public health problem. Secondly, the program reinforced known concepts, but more importantly, it introduced new concepts and skills. And this is really as a policy brief, as a policy proposal communication tool, as well as economic evaluation. And in our cohort, we utilized cost-benefit analysis using a decision tree. And this was a new approach or a new skill. An important milestone is the adoption of the proposed recommendations. And what we anticipate as success for particularly the policy brief that I worked on is the implementation of the recommended interventions and the realization of the intended impact, which is 0 by 2030. Challenges were first, but I personally found that the subject matter interest, outweighed the challenges that were first. An important challenge would be that the program is indeed time intensive, with the majority of participants being employed public health professionals. Thus, they were competing needs that had to be balanced. But nevertheless, I believe that the diversity of the teams, and in my context as well, the management of the policy brief team enabled success. Reflecting on how the program impacts my work, firstly, I am capacitated to utilize the policy brief as an approach to drive key recommendations forward. I am better equipped to analyze a health problem and evaluate recommendations and interventions, and more importantly, being able to incorporate economic evaluation methodologies in this. I think I came into the program with a pre-formulated strategy. They're well-described or well-established strategies for a One Health approach to disease control. But the D2P program, through the D2P program, I was able to take a step back and think through the strategies that we had proposed, as well as evaluate other strategies, evaluate them, and thus was able to and am able to articulate with confidence, the proposed policy brief options. I'm a field epidemiologist, a researcher, and a postgraduate supervisor. And through this, I can identify opportunities already where the policy brief can be applied as an effective tool to communicate and escalate recommendations for public health problems. The D2P seeks to build cadres of public health professionals who can utilize health data to drive policy agenda, formulation of a policy agenda, as well as the development and implementation of public health policies. Training of trainers will develop a pool of trainers or mentors that will conduct the local D2P trainings, as well as support the regional expansion of the program. Within our cohort, and even during the training of the trainer workshop, the economic analysis was identified as a skills gap. And to ensure and facilitate sustainability, an economic analysis workshop for the recently trained D2P trainers or mentors is planned for next year, 2024. As shown in this presentation, policy briefs were presented at the policy forum and are being disseminated further through presentation at conferences, publication, as well as tabling at relevant local platforms. But to ensure a sustained dissemination strategy, the public health bulletin, which is hosted by the NICD, will introduce a policy brief format as a report type, and so provide an additional sustainable platform for the further dissemination and advocacy of the policy briefs. I will close off my presentation by reflecting on the impact of the D2P program on the mandate of the Ministry of Health, and in my context, the Department of Health. Indeed, as highlighted by Andrew, the D2P capacitates health workforce to develop skills to use public health data to advance public health policy. And it bridges the gap between public health professionals and policymakers. The first cohort of the South African D2P program included a diversity of public health cadres, few of whom were from the Ministry of Health. Policy briefs developed ranged from ranged over a number of key public health topics. And looking at the mandate of the Department of Health, which includes improving the health status of the population by preventing illness and disease, it is evident that the policy briefs that were developed by the first cohort of the South African D2P program speaks to this mandate. And we have proposed and facilitated through the D2P program the implementation of policies and interventions that address identified public health problems locally and nationally. I'd like to acknowledge the following organizations, and thank you very much.
Thank you very much, Ruvimbo, for that sharing your very practical experience with us. And I believe there is a lot that participants have learned from you. At the right time, probably they will ask questions. But as I said earlier on, please post questions in the Q&A as we move along, because we shall have only one session for all the questions. We're not going to break it up. Now, from data to policy, now we are moving on to public health emergency response. And to discuss that, we want Dr. Mohammed Lamorde to take us through the 717 timeliness metrics. Dr. Lamorde Mohammed is the director of 717 Alliance, hosted by Resolve to Save Lives. He coordinates the provision of technical assistance, grants, under contract, and project activities to enable countries to achieve the 717 target. And prior to this role, he was the head of Department Global Health Security at the Infectious Diseases Institute, Makerere University in Uganda. He also served on the incident management team for disease outbreaks at the Ministry of Health in Uganda. He's a fellow of the Royal College of Physicians of London, and he holds a doctorate degree from Trinity College, Dublin. Mohammed, the floor is yours.
Thank you very much, Dr. Ario, and I want to thank the organizers in IANPHI for giving me the opportunity to talk a bit about the 717 target today. Public health institutes really are at the heart of our public health control programs when it comes to emerging infectious diseases and outbreaks. But in other fields, we have seen incredible successes that have come when quality improvement or performance improvement systems have been included. We've seen that in HIV with the setting of the 1990 target that went on to 95, 95, 95 targets. We've seen it in TB. We've seen it also in surgery with the introduction of surgical checklists. So what we want to talk about here is putting performance improvement really at the earliest stages of an outbreak. At that point, we have more resources and the outbreak really has less impact on the community. And if we rigorously apply quality improvement or performance improvement strategies at that point, we're more likely to prevent epidemics. And so what is the 717 target? It has three elements, but it really has to be viewed as a single target. The first 7 days in the target reflect the time to detect. And what we say here is that it should take no more than 7 days from the time of emergence of the disease to the time of detection. The one in the 717 takes the time to notify. That's the time to notify public health authorities about the event. And then the last 7 is the time to complete early response actions that are appropriate for the outbreak. As I said, it's best to look at 717 as a single target. What we're trying to do is to bring these three metrics together such that we have a disease that has not had enough time to spread in the community, that was rapidly notified to public health authorities, and an effective and early response was implemented at the beginning. And why is this discussion relevant today? In 2022, ministers of health adopted the regional strategy to transform health security in Africa. This is under the WHO's Regional Committee for Africa meetings. And one specific recommendation were that countries in Africa adopt and use the global 717 target. Now, 717 is a global target. However, the proactiveness of ministers of health in Africa to adopt and start to use this target is really commendable and was recognized in 2022 and also reinforced in last week's regional committee meeting in Botswana. So what happens when we implement 717? With 717, we're really looking for bottlenecks, right? We want to understand what makes us not meet those targets. So we want to identify and quantify them, and then come up with short-term and long-term actions to drive improvement. 717 can also help us to prioritize what we should finance. By looking at what's going on in the real world setting, countries are better able to identify the problems for which resources should be allocated and complementing other assessments that the countries may be doing, such as the JEE and the SPA. With the simple metrics of 717, political leaders and donors can clearly visualize the resource needs and necessary policy interventions, substantiated by clear domestic data of the outbreaks that they are having. And then we can also use 717 for accountability and for reporting. So as I mentioned, the heart of 717 is really to look out for what makes us, what hinders our timeliness for detection, notification, and our timeliness for early response. But we also want to identify factors that help us succeed, and we call these enablers. And we use enablers to support advocacy objectives by, for example, demonstrating best practices that can then be reinforced or replicated. And there are three elements. First, you want to capture the data around 717, and you can do this either in real time during an outbreak, where you check to see which early response actions have been completed, what is being delayed, and feedback that information either at national task forces or any other public health stakeholder meeting. It's also possible to review retrospectively from past outbreaks to really see what went well and what went wrong using the 717 target. But once you've gotten those data, you want to identify the bottlenecks, you want to know the enablers, and then you want to identify what immediate actions can then be put in place to overcome bottlenecks, but also identify those longer term actions for which planning may be necessary. And this might include, for example, incorporation of prioritized activities in national action plans for health security. And so to implement 717, tools are available. We have a tool to document the dates of emergence and to assess if targets were met. We also have a tool to identify the bottlenecks as well as the enablers. And then we have a tool to capture information such as proposed actions. And then a critical element of 717 is ensuring that the information that has been captured is shared. It's critical that we're able to go back and share this information to stakeholders that are responsible either for response or also responsible, for example, for allocating resources that would be then used for preparedness and response activities. It's possible to synthesize information across multiple outbreaks, and this can be done by country. And then looking across multiple outbreaks, we could see whether timeliness metrics were met for detection, notification, and response across a range of outbreaks. This helps countries to identify the area, for example, where they may need to focus more on. And sometimes you can disaggregate by disease type and actually see that, for example, vaccine-preventable diseases may take a longer time for detection, and then you can target resources around that element. And over time, it can be used as a tool for advocacy and accountability. What we really want is to see that there's a curve where the number of events that meet the entire 717 target progressively increase. We're actually looking for countries to come up with a goal, for example, to say, for example, by 2030, 90% of all events that occur in the WHO Africa region, for example, meet the full 717 target. So that element of advocacy and accountability can also happen by tracking our overall performance in time. One of the good examples of 717 in action was the Ebola Sudan virus disease outbreak. That was the 2022 outbreak in Uganda. And 717 was used first at the initial stage, but also as part of the after-action review. It was assessed and there were delays in detection, largely driven from low clinician recognition when VHF cases presented at private facilities at the early stages of the outbreak, but also poor detection from the community. Notification happened within a day, and early response actions really happened within 9 days, but there were some challenges with isolation units, as well as delays in accessing funds for contact tracing. Having said this, we really have to commend the government of Uganda as one of the initial countries to pilot this work, deploy it in real time during an outbreak, but also to use it for immediate action, which happened during the outbreak where these problems were addressed. But for those that required longer term action, such as training of clinicians on IDSR, that was then put into longer term plans, including private clinics and private facilities, which had not previously been beneficiaries of government rollouts. The evidence around 717's use comes really in two main publications in the Lancet. One really highlighting the model, and then the second showing the performance from 5 countries. 5 of those countries included Brazil and 4 African countries, Nigeria, Ethiopia, Uganda, and Liberia. And what was seen across 41 outbreaks then was that only 20 to 30% of events met the full 717 target. So we still have a lot of way to go. Last week, the WHO released guidance for early action reviews. And this guidance essentially incorporates the use of the 717 target, as well as all the tools that I have mentioned. This then provides countries with a document that can be used by public health institutes, emergency operations centers, to implement 717 in a simplified fashion. But I represent the 717 Alliance, and we are part of a group of stakeholders, a coalition of stakeholders. The Secretariat is hosted by Resolve to Save Lives, but countries are partners, academic institutes can also be partners, and we work by providing technical support to countries that are willing to adopt and rapidly scale up 717 in the country. We also have here resources that will be available. The links are here for easy access, and they will be available in the slides when they are disseminated. And if you're interested in learning more about how your country or organization can become a partner with the 717 Alliance, this is our email address. We would like to hear from you. And please also subscribe to our newsletter and join our learning network. Thank you very much for the opportunity.
Thank you very much, Moha, for that wonderful presentation. And I believe members have observations and reflections on what you presented. Members, we've come to the end of the presentations. We've had presentations by Andrew and Ruvimbo on data to policy, where they took us through data to policy. Andrew told us that data to policy is part of the data impact program, which of course has other components like scientific communication and public health bulletin writing. But particularly for today, we focus majorly on data to policy, which of course is meant to inform policies and programs. And and utilizes the available data that are actually within member states. And he also told us about the added value of economic evaluation to these policy briefs. And most importantly, took us through the process of developing these policy briefs, which included, of course, stakeholder engagement, policy brief completion itself, policy forum, and training of mentors. But most importantly, he mentioned about these policies being guided by national public health institutes for sustainability purposes. And of course, how policymakers within the Ministry of Health have managed, to change their policies based on evidence. And then Ruvimbo told us a lot about her experience, which was very enriching. She talked about the experience policy-making process in South Africa and its implementation, and gave us a lot of examples. But most importantly, what lessons can we learn from what Ruvimbo presented? She talked, of course, about peer-to-peer learning, self-learning, professional development, and meaningful use of data. But also she talked about the value of mentorship and bringing to the fore neglected public health problems that sometimes, ministries may not be thinking about. But once a policy brief is released, then it's brought to the fore, which was actually quite enriching. Now, then, of course, Moa took us through something very exciting, and that is the 717 targets, where he talked about the 3 elements: the 7 days to detect, 1 day to notify, and then the 7 days to complete response. But most importantly, is about controlling outbreaks at source, and the interest that African leaders have developed to the extent that African ministers actually met and made some declarations around that. Importantly, of course, he talked about performance improvement, prioritization of financing, accountability, and reporting, amongst others, and identification of bottlenecks and enablers, and also most importantly, tools for action that countries can actually pick from there and see how they can actually develop their targets. And he wound up by, of course, talking about sharing of information, which is actually very critical, and how the information from 717 has informed WHO guidance to member states. And of course, he talked about the 717 Alliance, calling on members who want to join. So I would want us to start the discussions around those areas, but also to remind us about issues around national public health institutes. I know we have directors here, and also senior staff who are within the national public health institutes. How do you think the national public health institutes worked quite well with policymakers in your countries? It would be good to share some of this information. And were there mechanisms to build consensus around this policy making? It would be good for us to share some of these things so that we don't reinvent the wheel. And how did National Public Health Institute deal with lack of data for countries that are implementing data to policy? Was there such scenarios of lack of data, and how did they manage? How did they go around it? Okay. And then, of course, the other thing is about the ministerial decisions themselves within those ministries. Do they take decisions based on those policy briefs? Do they do things still the usual way? Okay. And can national public health institutes influence them in whatever they do? So I think with those, we could actually start the discussion. The panelists can respond to some of them, but also the directors who have logged in could share some of the experiences with us, and then we could start the discussion from there. Also on the chat, there are some 2 questions for. I think one is for Andrew. One is for Andrew. One is for. Let me see. Yeah. How do you monitor if these policy briefs are really implemented? Yeah. It goes back to some of the whatever I asked earlier. Yeah. So that is for Andrew. And then the other question is, I can see the benefit of training public health professionals at the point of delivering data directly to policymakers. Do you also train throughout the organizations at the point of gathering data? Does this influence the data acquisition with the aim of influencing policy? This is to Andrew too. So Andrew, you could actually start, and then others could join you.
Okay, yeah. So
for the participants, you can continue posting on Q&A, or you can raise your hand, please. Andrew, start.
Okay, thank you. Can you hear me?
Yeah, sure.
Okay, great. So every time that we conduct a policy training like D2P course, we do that in coordination with a CDC Foundation or Vital Strategies coordinator that is located in the country that we're working in. And they're usually housed within the NPHI. So we rely heavily on those people to continue monitoring this implementation of policies. So we'll regularly email back and forth, have calls, discussions. We even meet in person sometimes and talk about the policies that were developed, where they are at current status, and where they think that they're going. So we use that connection of the country coordinator really to get that information and monitor that, and then we collect that information and house it within kind of like our like a backend database spreadsheet, really, to identify how many policies we've developed and passed, and topic points, and what impact they've had. But yeah, that information is collected from the country coordinator. And then the second question on training for gathering data or helping people gathering data and how it influences policy. I think the main arm of the Data for Health initiative is the CRVS program, which is Cancer Registry and Vital Statistics. So a lot of the work within that program is set up to getting those databases good, reliable information that can be used in something like our data impact side, which is developing policy based on those numbers. So while we don't necessarily train people on how to collect data, but we train them how to obtain it for policies. So one thing I could kind of elaborate on is we will take policy or we will take participants and try to get them to use the best quality data that they have available. So whether that be raw data from the health department or summary statistics from a division or something of that nature to influence policy. So yeah, I think that kind of covers your question, hopefully.
Okay, thank you so much, Andrew. Any other comments, questions? Any experience, especially from Africa, of NPHI is influencing policy decisions, just like the way Ruvimbo presented. I know we've had that kind of experience in Uganda too, where we actually influenced key policies. Moha, what is the experience with the implementation of 717? Have all African countries adopted the use of 717 in response?
So thanks for that question. And so, really there are about 14 countries worldwide that are in some stage or another in terms of implementing 717. I mentioned countries that were part of the initial pilot, Uganda, Nigeria, Ethiopia, Liberia. So those countries have had the longest experience. But more recently, Sierra Leone and Rwanda, as well as DRC and Zambia are in different stages of really consolidating and implementing 717. So we still have a long way to go. Part of the reason for presenting here is to raise awareness around this and also to ensure that there's awareness that there is support to accelerate implementation of 717.
Thank you very much. Point taken. Any other questions, comments? Charlotte, how much time do we have left?
We have 20 minutes left, but if there is no other question, maybe we can finish a little bit earlier, I guess. It's up to you, Dr. Alex.
Okay. Okay, it looks like there are no any other questions. So let me thank our participants for joining in. I know we've taken long to have another webinar, and we hope to have one more webinar before we close the year. We shall communicate to our ardent participants soon. But thank you so much for logging in and for listening. I believe there's a lot that you've learned from these two major topics today. I want to thank staff from National Public Health Institutes and Ministries of Health who have joined, and of course the directors who found time in your busy schedules to join and listen to us today. I want to thank our interpreters. Sometimes they do a lot of work behind the scenes, but sometimes we forget to thank them. Thank you very much for all that you've done for our listeners who do not speak English as their first language. And of course, I want to thank IANPHI for organizing the webinar, but also for all the support that you've given to IANPHI Network. Thank you very much. And I wish you all a wonderful day, night, until we meet again. Bye-bye.